You know that nagging worry as a kid? Maybe a little ache that just won't go away, perhaps a slight limp that people start to notice?
Uh-huh.
Today, we're diving deep into one potential reason behind that. Perthes disease.
Right.
Think of this as your shortcut, really,
Right.
to understanding this specific childhood hip issue.
Exactly. We're focusing right in on Perthes disease, or leg calvade Perthes disease, a condition affecting the hip joint in children, typically between the ages of 4 and 10.
4 to 10, okay.
Yeah. And the core of it is a temporary disruption of blood flow to the head of the femur, that's the ball part, at the top of the thigh bone.
Right, the ball that fits in the socket.
That's the one. This lack of blood supply, what we call a vascular necrosis, well, it can cause pain, that noticeable limp we mentioned, and just trouble moving the hip properly.
It tries to heal itself.
It does, but the key thing is how it heals after this period of, reduced blood flow and bone cell death. This whole process, the avascular necrosis of the proximal femoral epiphysis, then the abnormal growth, and the bone remodeling, that's really what we need to unpack for you today.
Okay, so Perthes prime time is those early school years, 4 to 10. And the main problem, the root cause, is this blood supply getting cut off. What are the very first signs a parent, or maybe even the child, might notice?
Well, the initial clues often creep in pretty gradually. You might see the child developing a mild, kind of persistent hip pain. Sometimes they describe it as just a dull ache, maybe in the groin or down the thigh, or sometimes, surprisingly, just in the knee.
The knee. That could throw you off.
It really can. The other big sign is a limp that develops over time, not suddenly. And if you watch them move, you'll probably notice they can't move their hip quite as freely as before, especially in certain directions.
Okay, and if they get an x-ray?
Ah, yes, the X-ray. It can show some key changes. Sometimes early on, the space within the joint looks a bit wider than normal. Later, you might see the round head of the femur looking, well, smaller or maybe a bit flattened.
And you mentioned it's more common in some kids than others. Is there a pattern there?
Yes, definitely. It really shows a preference for boys. And it's interesting, while it usually just affects one hip, you can see it in both hips in around maybe 10% of cases.
Right. Now, when we think about what actually kicks this whole thing off, what's the current thinking on the cause?
The honest truth, the precise trigger for Perthes disease is still a bit of a medical mystery.
Really?
Still, yeah. However, the central issue we do understand is that something interrupts the normal blood supply to the femoral head. It's this interruption that really starts the cascade, leading to the bone weakening and eventually changing shape.
So no single aha moment for the cause. But are there things that seem to make a child more likely to get it? What risk factors should we know about?
Absolutely. The strongest link is simply being a boy in that 4 to 10-year age bracket. The peak age seems to be right around 6 years old.
6 years old, okay.
And that ratio of boys to girls is quite stark, roughly 4 boys for every 1 girl affected.
Wow, 4 to 1.
Yeah. We also see a higher risk in kids who have a family history of Perthes, which suggests there might be some genetic component.
Makes sense.
And interestingly, factors around pregnancy and early childhood seem to play a role too. Things like low birth weight, if the mother smoked during pregnancy, or even exposure to secondhand smoke afterwards.
Okay, so the blood supply gets interrupted. Can you walk us through what happens next, step by step, inside the hip, the pathophysiology?
Sure. It's kind of a cascade, really. The reduced blood flow leads to ischemia, basically. The bone cells aren't getting enough oxygen.
Ischemia, right.
Then comes necrosis, where those bone cells in the femoral head actually die off. As a result, the bone just gets weaker and it can start to change shape, even under the normal forces of just moving around. The initial key event is this avascular necrosis, and it often happens alongside a delay in ossification.
Ossification, meaning?
Meaning the process where the growth center of the femoral head hardens into proper bone. That gets delayed.
So the bone weakens and starts to kind of deform.
Exactly. And while the bone's going through all this, the articular cartilage, that smooth, slippery layer covering the end of the bone, it keeps growing. But because the bone underneath is losing its shape, the cartilage can get distorted, maybe thicker than it should be.
Ah, I see.
There's also an issue with how that cartilage turns into bone, so you end up with maybe too much calcified cartilage. Eventually, the body does try to fix things. It starts growing new blood vessels back into the femoral head. That's called revascularization.
Okay, trying to repair itself.
Right, and it usually starts from the edges and moves inwards. Symptoms often become really noticeable when the weakened bone just under the cartilage can't support it anymore and starts to collapse slightly, sometimes even getting tiny cracks or subchondral fractures.
It sounds like a really slow, complex process of damage and then attempted repair.
Yeah.
Now, if a child in this age group, say 3 to 10, shows up with a limp and hip pain, Perthes isn't the only possibility, is it?
No, absolutely not. That's a really crucial point. A limp in a child that age can have several causes.
Like what?
Well, common things we think about first include transient synovitis, sometimes called irritable hip. It's basically temporary inflammation that usually gets better on its own.
Okay, the grumpy hip.
Exactly.
Yeah.
And of course, actual injuries like fractures or soft tissue strains. But when we're specifically considering Perthes affecting just one hip, we need to rule out more serious things too.
Such as?
Things like septic arthritis, that's a bacterial infection right in the joint, which is an emergency. Also, sickle cell disease, which can affect blood flow in bones generally. Then there are some rarer bone disorders like spondyloepiphyseal dysplasia tarda or Gaucher's disease that can sometimes look similar on imaging.
Okay.
Even something called eosinophilic granuloma, a rare type of bone lesion, and as I mentioned, transient synovitis can sometimes mimic the early stages. So considering all these differentials is vital to get the diagnosis right.
Absolutely. Getting it spot on is critical.
Yeah.
So how common is Perthes disease? Do we have numbers on that?
We do. The estimated incidence is somewhere around 5 to 15 cases per 100,000 children under 15 each year.
Okay, 5 to 15 per 100,000.
Yeah. And again, that typical age range is mostly 3 to 10 years old. Bilateral cases affecting both hips happen in about 15% of kids.
15%.
And that male predominance holds true, around 4 or 5 boys for every girl. It's also interesting that Perthes seems to be less common in non-Caucasian populations.
Fascinating. So a young boy, maybe around 6, with a limp that's been coming on slowly and some hip pain, Perthes should definitely be on the radar. Let's dive into exactly how it usually presents the clinical features a doctor would be looking for.
Right. The classic picture is a child experiencing a gradual onset of pain, usually in the hip or groin area.
Gradual is key there.
Yes, very much so. And as we said, the pain can sometimes radiate down the thigh or even just present as knee pain, which can be confusing. The limp is usually something that starts subtly and just gets more obvious over weeks or maybe even months.
Okay.
On examination, a really key finding is a reduced range of motion in that affected hip, particularly when trying to move the leg away from the body. That's abduction. And when rotating the leg inwards, internal rotation, those are often limited and sometimes painful.
Yeah.
And as we mentioned, X-rays eventually show those telltale signs, maybe that initial widening of the joint space, then later the femoral head appearing smaller and flatter. It's important to remember this all happens slowly, usually without any specific big injury or trauma.
Right, no sudden event.
Exactly. And while it's usually just one side, remember that roughly 10% will have it in both hips. Also, typically the child won't seem generally unwell. No fever, no major signs of inflammation like significant swelling or redness right at the joint.
And are there specific ways they might walk or specific tests that give clues during the exam?
Absolutely. You might see what we call an antalgic gait. That's basically a limp where they spend less time putting weight on the painful leg. So the stance phase on that side is shorter.
Trying to get off it quickly.
Precisely. In later stages, you might notice a Trendelenburg gait. That's a bit more complex. When they stand on the affected leg, their pelvis might drop down on the opposite side, the non-affected side. It suggests weakness in the hip abductor muscles.
Okay, the muscles aren't stabilizing properly.
Exactly. And a specific test we often perform is the roll test. With the child lying relaxed, we gently roll their whole leg inwards and outwards. In Perthes, this often causes some guarding, muscle tightness, or pain, particularly with that internal rotation.
Okay, so based on these signs, if a doctor suspects Perthes, what's the next step to confirm it? What investigations usually get done?
The first step is typically plain x-rays of the pelvis. We usually get a standard front view, an AT view, and also a frog leg lateral view. That's where the hips are bent and turned out, giving us a good side view of the femoral head.
Frog leg view.
These x-rays can often show those characteristic changes we talked about, the density changes, the flattening, maybe fragmentation. But it's really important to know that in the very early stages, the x-rays might actually look completely normal.
So a normal x-ray doesn't rule it out early on?
Not necessarily, no. If the suspicion is high but the x-ray is normal, we might move to more sensitive imaging. A technetium bone scan, or more commonly these days, an MRI can be really helpful.
MRI. Okay.
Yeah, MRI is great because it can show the disruption of blood supply and the extent of the necrosis much earlier than plain X-rays can. We also use repeat X-rays over time to monitor how the femoral head is changing, looking for that size reduction or deformity developing.
And sometimes you need an even closer look inside the joint.
Yes, in certain situations, we might do an arthrogram where a special dye is injected into the hip joint and then X-rays are taken, or use MRI again to get a better picture of how well the femoral head is fitting into the socket, the acetabulum, especially as the hip moves.
Well,
We call that congruency.
checking the fit.
Exactly. And of course, if there's any real concern about infection septic arthritis, then a hip aspiration is crucial. That involves taking a fluid sample from the joint to test for bacteria. But generally, these investigations help us see the extent of the avascular necrosis, track the bone remodeling, and just assess the overall health of the hip joint.
You mentioned monitoring changes.
Yeah.
Is there a way to classify how severe the Perthes is based on what you see on these images?
Yes, there are several classification systems, but one of the most widely known is the Catterall staging. It basically describes the progression based on how much of the femoral head is involved on the X-rays.
Okay, Catterall. What are the stages?
Well, stage 1 is very early, maybe only clinical signs or subtle X-ray changes. Stage 2 shows some sclerosis, increased bone density, maybe some small cyst-like areas, but the overall round shape of the head is still pretty much preserved.
Right.
Stage 3 is when you start to see the femoral head losing its structural integrity, beginning to collapse or flatten more significantly. And stage 4 is the most severe, with widespread collapse and flattening, and often changes in the shape of the socket, the acetabulum too, as it tries to adapt.
So quite a range of severity.
Definitely. So when we talk imaging for diagnosis and severity, those plain X-rays, AP, and frog leg are the first line. We look for those key features: increased density, flattening, fragmentation, maybe that joint space widening early on. And if those are normal but we're still suspicious, then bone scans or MRI come into play because they are more sensitive early.
This gives us a really good handle on diagnosis and assessment. Now, let's talk management. Once a child is diagnosed, what's the plan? What are the main goals?
The main goals of treatment really are threefold. First, manage the pain and any other symptoms the child has. Second, maintain a good range of motion in the hip joint. And third, crucially, achieve what we call containment.
Containment. What does that mean exactly?
Containment means keeping the femoral head, the ball, well seated and covered within the acetabulum, the socket. The thinking is that if the femoral head is held nicely within the round socket while it's healing and remodeling, it's more likely to heal in a rounder, more functional shape.
Ah, using the socket as a sort of mold.
That's a good way to think about it, yes, like a natural mold to guide the healing.
Okay, and how do doctors typically try to achieve this containment? Is surgery always the answer?
Actually, no. In many cases, especially in younger children, generally those with a bone age less than 6, non-operative treatment is often preferred first.
So under 6, less likely to need surgery initially.
Often, yes. Non-operative management usually involves activity restriction, limiting activities that put a lot of stress on the hip, like running and jumping, and sometimes limited weight bearing on that affected leg until the bone healing, the ossification, is further along.
Right.
Physiotherapy is also really important here. It helps maintain the hip's flexibility and range of motion, particularly that abduction and internal rotation we talked about.
What about things like braces or casts?
They are sometimes used, things like abduction braces or even casts in specific situations, but the evidence supporting how effective they are compared to just activity modification and physio is, well, a bit limited and debated. We also use NSAIDs, non-steroidal anti-inflammatories, for pain relief as needed.
Okay.
And it's encouraging that this non-operative approach can lead to good outcomes in a fair number of patients, maybe up to around 60%.
So often starting with these more conservative measures. What about when surgery is on the table?
Surgery might be considered if we can't get good containment with non-operative methods, or perhaps more often in older children, say over 8, or those who have more significant involvement of the femoral head from the start.
And what kind of surgeries are we talking about?
The main types are often osteotomies. That means the bone is surgically cut and then repositioned to improve the alignment. This can be done on the femur, the thigh bone, or on the pelvis.
Cutting and realigning the bone.
Exactly. Examples include things like a varus or valgus osteotomy of the femur, or maybe a pelvic osteotomy like the Salter or Pemberton procedure, or even a shelf osteotomy. They're all aimed at getting that femoral head deeper into the socket or improving the coverage.
Okay.
In some situations, hip arthroscopy keyhole surgery might be used, maybe to look inside, clean things up, or address specific cartilage issues. There's also a technique called hip arthrodiastasis, which involves using an external frame to gently distract or pull apart the hip joint for a time. It's thought to reduce pressure and potentially improve blood flow, but it's a bit more controversial and not as commonly done.
Right. So several surgical options depending on the situation.
Absolutely. The key is that the management plan really needs to be individualized for each child. The goal is always to relieve their symptoms and give the femoral head the best chance to heal with a good shape. Regular monitoring with exams and imaging is crucial to track progress and adjust the plan as needed. An evaluation by a pediatric orthopedic surgeon is really essential.
Sounds like a very personalized approach is vital. Thinking long-term now, what's the typical outlook for children who've had Perthes? What does the prognosis look like?
Well, the long-term prognosis really depends on a few key things. The child's age when it started is a big one. Also, how much of the femoral head was actually affected by the necrosis, and of course the treatment they received and how well the hip responded.
Age seems really important.
It really is. Generally, we see better outcomes when the diagnosis is made early and the right management is started promptly. The good news is that, overall, the prognosis for most children with Perthes is actually quite favorable,
That's reassuring.
particularly for children who are younger than 6 years old when it starts. They tend to have good outcomes, often regardless of the specific treatment approach, mainly because their bones just have so much more potential to remodel and reshape effectively.
More healing potential when younger.
Exactly. Studies have shown that well over 80% of people who had Perthes as children have good hip function well into their 40s.
Under their 40s, okay.
However, it is important to know that some individuals may eventually develop significant arthritis and require a total hip replacement later in life, often decades after the initial disease. But that younger age at onset, below 6, is definitely a strong positive prognostic factor.
So younger age at diagnosis is definitely a plus. What can happen if Perthes isn't treated or maybe isn't managed effectively? What are the potential complications we need to be aware of?
Yeah, unfortunately, if Perthes isn't managed well, or in some severe cases, even with good management, there can be long-term issues. These can include a permanent deformity of the femoral head, which can lead to ongoing hip dysfunction.
Like what kind of deformities?
Well, you can end up with what's called coxa magna, where the head and neck of the femur are just abnormally large. Or coxa plana, which is the term for that persistent flattened shape of the femoral head. Coxa breva means the femoral neck is shorter than normal. And there's something called hinged abduction.
Hinged abduction.
Yeah, it's where the deformed, often flattened and widened femoral head kind of levers or pushes against the rim of the acetabulum when the hip is moved outwards into abduction. It causes a block to movement and can cause pain and damage over time.
Ouch.
Other complications include a difference in leg length, the development of osteoarthritis much earlier than usual, and just persistent limited motion or stiffness in the hip.
And arthritis is a big concern long term.
It is. While many people tolerate some degree of femoral head deformity reasonably well in the short and medium term, research suggests that perhaps around 50%, maybe half, may go on to develop significant arthritis requiring treatment by the time they're in their 60s.
By their 60s, okay.
Yeah. So other potential issues are that persistent pain or limp, general long-term hip problems, and we shouldn't forget the psychological impact on the child, especially with the activity restrictions that are often needed during treatment. And in some rarer cases, you can even get premature fusion of the growth plate near the hip.
It really underscores why getting that early diagnosis and proper tailored management is so incredibly important.
Absolutely.
So just to quickly recap for everyone listening, Perthes disease. It's a childhood hip condition, mostly hitting kids aged 4 to 10. The core issue is a temporary loss of blood supply to the top of the thigh bone, the femoral head.
Right.
This leads to symptoms like hip pain, sometimes felt in the knee,
Yeah,
a limp, and trouble moving the hip, especially outwards and inwards rotation.
exactly.
We don't know the exact trigger, but it's definitely more common in boys.
Mm.
Risk factors include that age group, being male, family history, and maybe low birth weight or smoke exposure.
That covers it.
Diagnosis involves a good history, physical exam, looking for those signs like limited motion and maybe specific gaits, and imaging, starting with x-rays, AP and frog leg. But sometimes meeting MRI if x-rays are normal early on. Catarrhal staging helps classify severity.
Perfect.
Management aims for pain relief, keeping the hip moving, and containment, keeping that femoral head nicely in the socket while it heals. often starts non-operatively, especially in kids under 6, with activity limits and physio. Surgery, like osteotomies, is an option for older kids or if containment isn't achieved.
You've got it.
Prognosis is generally good, especially if caught young, but potential long-term complications like deformity, leg length difference, and early arthritis exist if it's severe or not managed well.
A very clear summary, and I think the key takeaway for you listening is that while a Perthes diagnosis can definitely be worrying for a family, recognizing those early signs, that persistent limp, that hip or groin or even knee pain, and getting a timely evaluation by a specialist, ideally a pediatric orthopedic surgeon, is just so crucial. It really shapes the long-term outcome for that child's hip.
Absolutely. And if you are revising for your exams and looking for more high-yield resources on pediatric orthopedics, including conditions like Perthes disease, definitely check out PathMSRA.com.
And don't forget freemsra.com for a taste of what they offer. Lots of great material there to help solidify your knowledge.